Well, welcome all, and we're going to take a little, I'm going to get my screen shared. We practiced this, didn't we, Mike?
We did. It works.
Except, there we go, slideshow. Okay, nothing to announce. And it's number 2 cause of fatty liver. And for our, I got this window right in front of the slide, so we'll get it over the side. There we go. We're going to explain the difference between the definitions NAFLD, and NASH, and how they're clinically important, especially in correctional settings. We'll define diagnostic monitoring strategies for patients with NASH. And we're going to talk about some of the current and future management options, which are happening really fast finally. This talk I gave a while back for NCCHC based on the 2018 guidelines, and nothing's really changed until last year. The American Association for Clinical Endocrinology, with involvement of ASLD, came out with guidelines February that were quite aggressive, actually, like they often are. The American Gastroenterology Society also published algorithms and guidelines last year. But the big one, I got an email last week announcing that my society is just now going to dump new guidelines, and they're not even in print yet. And so I've had to modify my slides, and you'll see some red entries where I think it's important how these new guidelines are going to shake things up some. First, you really can't talk about this topic without a little discussion about what a liver test is. And these are some of the things that are going to really change things for all of us, private practice and corrections. We think of liver chemistries in hepatology as the AST, ALT, sometimes the GGT, especially alcoholics, and the alkaline phosphatase. And then you have your liver function tests. And these all can be normal in liver diseases, and they're especially often normal in fatty liver disease. And ALT is going to be the test we talk about the most because it's felt to be the most accurate. This is one of my prior patients in correctional practice. And when you go back in history, you find out he was heavy in 2008, lost some weight, got heavy in 2012. And here, when I saw him in our segregation unit, that's actually hepatitis C. And none of it had caught anybody's attention because our lab, those were all normal liver tests. But you can clearly see what his normal baseline is. And then suddenly it's double that. So different labs, in fact, OHSU in our area is one of the highest normals. But as you see in the bottom right, the guideline that will come out in print any week now is going to define a normal liver test as less than 30 for both men and women. And that is going to create some problems. I just moved the window to, whoops. Because this represents 36% of actually all Americans. So we're going to have a huge number of our patients now, they're going to get told that their liver tests aren't normal. And that really suits the drug companies quite nicely when you look at the end of my lecture. So to talk about the definitions from the 18 guidelines, there's really 2 kinds of fatty liver. And the majority of people we need to think about are in this macrovascular group: alcohol, obesity, diabetes, especially type 3 genotype, Wilson's disease, which is usually going to be caught when you're young, and then these more rare conditions. But some drugs, methotrexate, steroids, amiodarone, and tamoxifen, can actually give you fatty liver on the own. And then the microvesicular type, also some medications, Rye syndrome, and these are some pictures. The person on the left, especially for American standards, would be a normal liver, but you can see some fat droplets. This would not be caught by an ultrasound. And in the central picture is what we're really talking about today, the standard fatty liver versus the slide on the right, which is the more rare intracellular fat accumulation that, as I mentioned, Rye syndrome and some of the more rare drugs, HIV drugs especially. When you look at fatty liver, obesity is in the majority of people the clear problem. I had a very busy slide in the past that I've replaced with this. Mike might even remember it, but there's multiple factors that determine people's fatty liver. So whereas 1 in 5 Americans has fat in their liver on ultrasound, only 1 in 20 of us are going to get in trouble. And so the definition, going back to definitions, fatty liver is strictly fat on a scan or by biopsy, and being more than 5% of the liver. NAFLD is fatty liver disease, and it encompasses the whole. So this is the word you'll see that encompasses all the issues. Now there's a group of people, I'll show a slide, that have lean NAFLD, and that's somebody who has steatosis in their liver and their BMI is normal. NASH is hepatitis associated with fat in the liver and evidence of inflammation either by liver function test or biopsy. NASH cirrhosis is simple as the name states. And then we've always had a group of people, especially before hepatitis C was diagnosed, with cryptogenic cirrhosis. And increasingly, we're believing that this group of people, which can be up to 10% of cirrhotics, are sneaky NAFLD people. But there's probably other diagnoses hiding, but increasingly NASH is being found to be the cause of these groups of people that we could never diagnose before. Now, you don't have to be overweight to have NAFLD, and it's actually 7% of Caucasians and 19% of Asians will actually have a normal BMI and look very normal, but you'll get an ultrasound for whatever reason, or a CT is even more accurate, and they'll have steatosis, and they differ genetically. And they even differ by their gut microbiome, which is becoming a huge issue in hepatology. In fact, at the National Liver Meeting this year, it was discovered that even our livers have their own microbiome. So you don't have to be overweight to have this, and especially in our Asian patients, we need to be thinking this when we have elevated liver tests or steatosis on the ultrasound. Prevalence-wise, it's 25% of the whole world. People in the Middle East and Hispanics are more prone to it. One of the few diseases where African Americans do better. They're in 13.5%. But in America, 21% of, and this is teenagers to adults, fatty liver. You can see even in the younger groups, 7.6 to almost 1 in 10 pediatric patients now with fatty liver disease. I don't have to tell you why. This is obesity rates in 2011, 2016, and 2021, darker and darker. And as much as we pick on the South, you can actually see that West Virginia and Kentucky, and I double checked this, are currently winning the prizes. Sadly enough, when I looked at the 2021 data, we've already beat this. This slide's from a little bit ago. And we're exceeding this expectation for 2030, sadly. So why worry about in corrections? Well, we're going to see there's some huge costs coming, but we don't have actually any higher rate of diabetes in corrections in the community. It's around 9–10%. Our patients do gain weight over time on average. And the combination, it's very, I did a quick search, and it's very different in different correctional situations. I think it has to do with incarceration, security levels, diets, activity levels. But overall, you can see the wide range from 43 to 73%. We're dealing with a population that's less healthy, less active, and often are getting higher carbohydrate diets. So if you take the United States as the big blue circle, we're talking 25%, as even high as 33% that have this group of fat in their liver. And then in that group, about 5% actually have active hepatitis. And then this group within that having stage 3 to 4 scarring. Mike and I have been doing hep C for a long time. And if our patients weren't stage 3, we were legally able just to ignore them. But with fatty liver, if you look at the survival curves, that doesn't work as well, because you can see an F2 stage 2 fatty liver person has a notable drop in survival. And so this disease is going to be taken very differently than what we're used to with our large number of Hep C patients. What's also interesting is, we're flooded with hepatitis C information, but blue is fatty liver, brown is hepatitis C, and green is Hep B. So with Asians, Hep B is a big deal, but for the majority of other people, fatty liver as you get older is the dominant cause of hepatocellular carcinoma and cirrhosis as well. And this, in fact, fatty liver passed alcohol in 2008 as the #1 cause of liver transplants, and is catching Hep C fast.
Wow.
Hepatologists don't really think of the stages of scarring like most primary care doctors. They talk about advanced disease and decompensated disease, and then 0, 1, and 2 sort of being normal levels of liver function. But I like this slide to help people realize that what you can see by lab tests, elastography, and ultrasound CTs just slowly develops. And it's really not a black and white situation where you're stage 0, 1, 2, 3, and then boom, you have cirrhosis. The other troubling thing with fatty liver disease is, as I mentioned with hepatocellular carcinoma, with hepatitis C and B, you're normally going to have a cirrhosis patient being the group at risk for cancer. But this has been duplicated besides the VA. Over a third of patients getting liver cancer with fatty liver are getting it before they have cirrhosis. So these are stage 3 people in this study, and less who are actually getting diagnosed with hepatocellular carcinoma. Again, showing that you can't use the same Hep C knowledge we've had in the past. And additionally, because of obesity, liver cancer is projected to 2030 to increase by 40% in the US. And the oral is HPV induced. So these are going to be the two cancers that we see increase, I think, dramatically, sadly. The problem is the cancer risk is small over time, but we're dealing with such a large chunk of America that's at risk. And so as this group progresses, we need to do a better job than we're currently doing at identifying this small group out of a very large number that we need to pay more attention to. As it shows here, it's a slow disease for most people. And what's important, and the new guidelines are going to highlight, is most people with fatty liver do not die of liver complications. It's an important group to catch, but the vast majority of people who die from fatty liver are dying from its effects on the body through other disease processes. And this just highlights that fatty liver even is a significant increase of liver, stomach, pancreas, and lung cancers. Of course, heart disease, osteoarthritis with the obesity. People with fatty liver have significant increases in kidney disease. If you have sarcopenia, that increases mortality. Of course, you got diabetes, and of course, these polycystic ovaries, and some of them are not life-threatening, but it's a constellation of diseases that most people are going to die from, and not direct liver disease. So I added this in here because this is really going to get stressed on the new guidelines being released. We're all used to ordering ultrasounds and finding things on ultrasounds, but the AASLD is going to really stress that ultrasound is not a useful part of NASH screening and treatment. So I snuck this in here just days ago after the guidelines got modified. When you have a person with hepatitis, I've used this slide in many presentations. You really want to screen for things that can imitate hepatitis, especially now that we're all going to get told really quick that our patients above 30 are not normal. Of course, we need to screen for hepatitis B, C, and HIV, especially in Northern Europeans. You need to screen for iron storage disease, hemochromatosis. In one study of idiopathic hepatitis, 25% of the people without a diagnosis had gluten sensitivity found to be associated. So many guidelines include celiac screening. And then we can't forget that many of the drugs that we're used to and bored with can actually cause hepatitis. I and many experts believe you should be selective in your screening with alpha antitrypsin. Wilson's disease is usually younger people. It itself causes lean fatty liver disease, though. And of course, testing people for autoimmune disease can get you in trouble. As per this one study where 864 people, even when their ANAs were 1 to 160, they were not associated with actual liver disease. So in a woman, high gamma globulin levels, with autoimmune testing, we should be selective. And then again, the next slide, we're going to talk about some drugs again. The ones in red are the most associated with hepatitis and have been listed over 100 times in the drug injury database. And these are things we see: sulfsalzine, for instance, statins, ibuprofen. So always, double check your patient's medications list that you know of and ask them what they're not, telling you they're taking. But the biggest problem with NASH is your patients often don't have elevated liver tests. So the ALT, AST are not sensitive for catching this. And 50% of people with actual disease and 80% of people with fat in their liver are going to have normal liver tests. So last year, the American Gastroenterology Association came out with this pathway. And I included this because it was easier to follow. And I believe these slides are available for anybody to reference later. And I'm certainly happy to share my slide set with anybody. And I highlighted the fact that this FIB4, and I'll show you the formula in a second, is 2.67. And the simplified algorithm for Hep C is 3.25. In Hep C, we're looking to treat and not miss a decompensated person, but a FIB4 of 3.25 is going to miss at least 2 out of 3 cirrhotic patients. So
Somebody's not muted. Could everybody please mute? Thank you.
So as we discussed, we need to catch people's at lower levels of fibrosis. So you need to drop the sensitivity cutoff down. So the guidelines from everybody is a FIB4 of 2.67. They want people referred to specialty care. We can't do that in corrections. We need to be able to do this intermediate steps ourselves. And we're going to go into that. So there's a number of options for better screening of our patients. And in the new guidelines that are just coming out right now, they emphasize the FIB4. I'm going to talk about all of them a little. The enhanced liver fibrosis test, which is a $200 proprietary blood test, and then FibroScan over the other imaging techniques. Oregon, we've purchased a long time ago shear wave elastography machines, but because of certain aspects, the ASLD at least is going to prioritize these as the preferred screening tests in fatty liver disease. This is the FIB4, which is now the ASLD preferred test. And as far as accuracy and sensitivity, you can't beat it. I'm a UW Husky, so you're going to get Husky stuff. They have an excellent, although it's Hep C based, a website for these calculators, whether it's MELD scores, you name it. So I screen cap their shot. In fact, as you can see here, the 325 FIB score for Hep C is only going to catch 65% of advanced fibrosis. So we got a lower cutoff, but easy calculated score. The NAFLD fibrosis score has been around for a long time. And I think it's obsolete as of last week. It gives you a score and a risk that your patient's normal. I've always liked it for this part. But it's not superior to the FIB4, and the FIB4 is easy to calculate. We've used the APRIA ratio around the world forever because it's so darn easy, but the FIB4 is just a little more accurate with the age components, especially in fatty liver. So this also, I think, is obsolete now. Elastography, initially invented to sample cheese in France. These machines have just proliferated. The machine that was first invented was made by Equisense called FibroScan. It doesn't show you a picture like this. This would be more similar to the machine we use in Oregon. But it measures liver stiffness, either through vibration or ultrasound or now MRI. So in the Boise area, this is all we have access to. They have two machines and they give you these pretty pictures. They're actually not more accurate by much than the simple ultrasound based, and they're 10 times more expensive. So $200 versus $2,000 at least. And if you look, it's important to know your machine and the cutoffs. So different machines have different scoring cutoffs. And what's even worse, I have slides that show in every disease there is, the cutoffs are different. So you need to either be comfortable with your machines and how you use them, or have a good reference radiology source for this information that's coming. The MRE, as you can see on the data on the right, far more accurate than a blood test or the AST. We've used platelets forever to try to screen for cirrhosis, but the standard of care is going to be a lab or ultrasound or MRE based additional step for these people that exceed the cutoff. And this study, of course, is from an MRE maker, touting how much better they are. This is comparing them to a elastography, cheaper ultrasound machine. Although they're more accurate, the numbers are not impressive for the benefit and the cost difference. These are showing the curves, being further to the left is more accurate. And so we're going to be seeing a lot of advertisements, I believe, for these new guidelines. And the VCTE is the machine I showed you that's ultrasound based. When you actually look at the difference in the $200 machine versus a $2,000 MRI, I would say that's not significantly different in corrections. And then what we're trying to avoid is with these non-invasive tests, not needing to do liver biopsies on people. And in fact, the VA has been doing this in Hep C for the longest time, where they, with blood tests and elastography, try to avoid liver biopsies. But this is additionally going to be important in corrections to try to minimize the people we're confused about with these other techniques. I've inserted this slide here because these are some important, the document's very large, but I just wanted to put these important aspects of the new guidelines they're going to be dumped on us soon. And that is, they're going to call anybody who has evidence of stage 2 to 4 fibrosis as being at-risk NASH. So this is really changing the bar of what we're used to. They're also going to link NAFLD to heart disease and non-hepatic malignancies. It's going to be much harder to claim, like in Hep C, that this is a liver-only disease, as we've done for, considered for so long, as when it comes to need to pay for medications, et cetera. The Endocrinology Society, the Gastroenterology Society, and the Hepatology Society are all on board that this is a multi-system disease beyond the liver. It's going to be very hard to avoid some of these expensive treatments, and we want to be careful who we put them on. Statins are recommended. I'm constantly dealing with patients who've talked to even specialists sometimes that, I have cirrhosis or I have advanced liver disease, I can't take a statin. The ASLD will now come out with in print that anybody with even compensated cirrhosis should be on a statin for cardiovascular disease, and even decompensated cirrhosis patients should be on a statin with careful monitoring if they're at high coronary vascular disease. Excellent data that statins improve outcomes in cirrhosis patients. This is a change. There will be a statement that diabetics are at high risk for NASH and advanced fibrosis and should all be screened for advanced fibrosis. 10% of our AICs are diabetic, 70% of them have NASH. And I've done the numbers. You guys can do that for your own state. That's a big number. Patients with prediabetes, diabetes, or 2 metabolic risk factors or imaging should be monitored by FIB4s every 1 to 2 years. If your FIB4 is greater than 1.3, an additional test should be done to screen for advanced fibrosis. We'll talk about those tests. And Mike, I got to move this little window. I can't see my bottom slide with the, oh, 1 second. Oh, there we go. Although standard ultrasound can detect hepatic steatosis, it is not recommended as a tool to identify due to low sensitivity in NAFLD. And boy, I myself in my community practice have been doing ultrasounds for the longest time with that in mind. Let's see, what did I skip? Nope. Now let's move to treatment. Treatment, as it's always been, is going to continue to be weight loss based, and reduction of calories by 500 to 1,000 calories per day and just 3 times a week or moderate exercise has all the best outcome data. Weight loss of 3 to 5% of body weight appears to be necessary to improve steatosis, but it takes 7 to 10% to see meaningful changes in tissue and lab results. Exercise alone can actually have benefits, but clearly combination diet and exercise programs have the best outcomes. This is a very old pyramid from 7-8 years ago, and it's still standard of care in outcomes. And you can even get scarring reversal, like we see with Hep C cures, if you can get somebody a greater than 10% weight loss. And so we're going to go to I'm going to show you some slides from the AACE guidelines on the management algorithm. Whoops, I'm sorry, I'm having to flip the screens around. So as I mentioned in the small print, 2 risk factors, a liver test over 30, prediabetes, diabetes. They want people risk and screened. The AACE, if you're not aware of them, has very aggressive guidelines for diabetes, for statins. So I'm going to go through these fairly quickly, but I want to highlight that we're going to see this for diabetes and for fatty liver, that instead of the days of sulfonylureas and metformin, there's going to be a flip in diabetes and fatty liver where GLP, SGLTs, and in this case, Actos bumps up, are going to be sort of standard of care, and they're not generic. I show this because it's part of the guidelines. I do not agree with AACE in their aggressive statin cutoffs, which are not consistent with ACA or United States Preventive Task Force, but you should know that they're pushing very low LDL goals. And then to the old school treatments, none are FDA approved yet. This is vitamin E. It's not for diabetics, but it has excellent data that if you put a non-diabetic on vitamin E with proven fatty liver disease, that their survivals, both in transplant avoidance and decompensation, are measurably better. So I very rarely put people on vitamin E, but it's an improvement in treatment. Actos, pioglitazone, has data going way back. And I don't think they'll ever, with a generic medication, seek FDA approval. But you can clearly see whether it's NASH or improvements in liver scores, strong statistical information, and other data. So summarizing these 2 old school medications, vitamin E's got a lot of risks, question of cardiac mortality at the dose we use, probably no prostate cancer risk. Actos, we've always been concerned of its weight gain. The risk of bladder cancer and osteoporosis is questionable. But now we're getting into new therapies. So until the new guidelines came out, this was standard of care until a week ago. And the AASLD also was demanding biopsy-proven disease, but that's actually going to change as we speak. So what's coming is from the AACE guidelines from last year, Actose and the GLP class, the semaglutide, Victoza, et cetera, are recommended with strong support in diabetes and biopsy-proven NASH. Second, clinicians must consider treating diabetes with these medications if the person's at elevated probability of having NASH, which of course 70% do. So with anybody with an ALT over 30, standard of care is probably going to be that these medications are going to jump are far more cost-effective medications. The other guidelines fit with what we're seeing from the AACE as far as diabetes, as far as prioritizing people by risk to SGLTs with cardiac, renal, or GLPs. And so you can refer back to these guidelines, but I wanted to point that out as a significant trend that's going to affect corrections will end the whole US. Now, the drugs under investigation are coming fast. Semaglutide has been around for a while. Victoza almost had FDA approval before it was pulled because Teva had a generic in the works. So they stopped all phase 3 studies for this. And semaglutide is now in phase 3 studies, and everybody's expecting it to have the first FDA approval strictly for fatty liver. And we all know about this class gaining incredible fame for weight loss in non-diabetics. And when you look at it for NASH, these are phase 2 studies, but it's well in the way of phase 3. And it's, as you would expect with a weight loss that's associated, showing tremendous by scan and lab parameter benefits in fatty liver. The new medication, and there's only one of them, tirzepatide, is a GIP GLP-1. And in diabetes, this medication is looking pretty amazing. The weight loss is fantastic. And as you would expect, it's also seeking approval in fatty liver. This medication is outperforming the GLP-1 class in diabetes, and I think it's going to be, from the MRI changes that we're seeing in other data in phase 2 studies, I believe this is probably going to be more effective than the GLP-1s, probably a year or two out from approval. What's even closer to approval is a medicine called etibacolic acid, and it's a bile acid FXR kind of medication. And this has been in research for a long time, but now it's close. It's not going to be cheap, and it's got really solid data that it's got the ability to interfere with scarring and have meaningful outcomes. You're also going to see an odd thyroid beta receptor drug probably get FDA approval. Resmetirom has actually been in research for quite a while and is looking good in final studies. So I'm only showing you the medications I think have a hope of getting prescribed. And when you look at studies with this interesting thyroid receptor drug, quite impressive improvements in liver function tests and all these lab parameters, and that are part and parcel to fatty liver disease. And I'm going to show you a slide. There's 1 million different receptors and points in the fatty liver cycle you can attack. Many of them have failed for years, but lanifibranor is probably going to be effective enough through these pathways that it is probably going to be a drug of use also. So looking at other treatment aspects that I pulled out of the pending guidelines that I thought were important is this, and these are the new, which are new from the 2018 guidelines, and that is bariatric surgery is going to be considered a therapeutic option to meet criteria for metabolic weight loss. It's now proven sufficiently that it resolves NAFLD NASH in the majority of patients without cirrhosis and reduces mortality from both cardiovascular and malignancies, including non-hepatic malignancies. So we're going to have to think about this in corrections. I don't, in Oregon, at least, this has not been something we triage our patients to. There are currently no FDA-approved medications for the treatment of NAFLD, but drugs approved to treat associated comorbidities with potential benefit in NAFLD may be considered in the appropriate clinical settings. As the slide I showed you from the ACE, semaglutide is going to be singled out by the AASLD to be considered for type 2 diabetes use in obese patients who have NASH or liver tests over 30, and the reasons why. Actose improves NASH histology and insulin resistance with or without diabetes and type 2 diabetes. And if you've noticed, there's no longer a requirement for biopsy-proven disease. Vitamin E can be considered in select individuals as it improves NASH in some patients without diabetes, I stress. And then the GIP, GLP-1 tirzepatide, improves steatosis on imaging, improves insulin resistance, and is associated with significant patient weight loss. SGLT2 medications are associated with reductions of steatosis by imaging, improve cardiovascular and renal outcomes, benefit CHF, and have moderate weight loss. These are all going to put additional pressure on the use of these medications that we're getting from the other societies. Now to go to the non-routine, I have a community practice as well, so I always throw this in. But what's funny is down here, get my pointer out, coffee. This will be an official AASLD recommendation. I hope I don't have to prescribe it, but 3 cups of coffee per day is in print as an AASLD recommendation for people with NASH of the hepatitis. Not every person with fat in their liver, but the data actually is impressive. Coffee is associated with a 29% reduction in NAFLD and a 30% reduction in the fibrosis. That's better than vitamin E or pioglitazone if you look at the prior data. The data in milk thistle is so common knowledge in our patient group that look into this that they made a statement and they're remaining neutral on whether milk thistle is effective. It's been on the canteen at times, but there are a number of studies that actually show fairly impressive milk thistle benefits, at least by lab markers and elastography, whereas actually at Hep C, it's not been shown to be useful at all. So this is really what's coming. I've seen many of these medications totally bomb. In fact, my first lecture at NCCHC was sponsored by Gilead for a dual agent they thought would be a miracle. Didn't pan out. But the medications I've mentioned, I really will be in our armamentarium. Some of them very soon, and some of them, a little ways down the road. But who knows what the future holds as these drug companies try to attack these different boxes that you see on the screen. And with that, I think, yes, I've ended with enough time to handle questions. Any questions on any aspect of our talk today?
So I have a question from the chat that was about the new medications, and I think this person was referencing the GLP-1s about their effect on chronic kidney disease, if there's any good or bad effect.
Well, that's pretty strongly listed in the diabetes data that the SGLTs are really the drugs of choice in kidney disease, especially with proteinuria. The American Diabetes Association is actually, so is the Nephrology Society, listing those as drugs for, if you have kidney disease with proteinuria, those are actually used independently of diabetes. I can't give you I didn't prepare those numbers, but the GLPs kidney benefits are not equal to the SGLTs. Comorbidities. So I see a question. I just got the chats up. I go back to that slide. Let me get to go up to my slides. the comorbidities with fatty liver disease, are we talking about liver related or non-liver related?
Hi, it's Michelle Staples Horn. It wasn't clear. The slide went by pretty quickly. And
Okay.
I was trying to see whether you were saying the morbidities were related to the other diseases, but I did not get the association other than, say, for example, being obese happens to also put you at risk for the heart disease and the fatty liver. So
Yeah. So are we talking about this slide?
Yes.
Yeah. So let's sit a little more time. So if I get my pointer, so people with fatty liver disease, as I showed in the VA study, have a significant, just like any cirrhotic disease, you're talking 1 to 2% per year cancer risk. And unfortunately, it shows up at stage 3 instead of stage 4. But for reasons not understood yet, at least in the research I see, they also have increases in stomach cancers, pancreas, and even lung cancers. In the final slide I showed, you can see all of the crazy changes that happen in a person's body, inflammatory pathways. There's a tremendous number of metabolic changes in people with fatty liver disease. This is not strictly just a fat in the liver process. So a significant increase in heart disease, and it's independent of diabetes. The people who do the worst are diabetic. But fatty liver disease, as I mentioned, you can be lean, non-diabetic, and have fatty liver disease with these additional complications. If you have fatty liver disease, you have a significant increase in chronic kidney disease. So does that help with the question?
So if
Yes.
I can be,
Go ahead.
thanks, Michelle. So that's independent of the obesity that can be associated with a lot of these things. That's what I think my question was, and I gathered that from Michelle, the same, similar.
Yes.
Correct. So if you look at obesity, this disease does not correlate well with obesity rates. You can see that even in the genetic rates between Hispanics to African Americans and Asians. So and lean people, there's clear genetic issues at play and insulin resistance. And so independent of weight, NAFLD has got clear people with disease, and I should call it NASH, have these increased risks. It's above and beyond what you would see with obese people. Now, the one exception is I cannot say that for sure about the osteoarthritis. I haven't looked into that or the gallstones. But the link with diabetes, the majority of people actually with cirrhosis, they have diabetes, but they cause each other. If you have advanced liver disease, it makes it easier to get muscle wasting. In fact, we screen this by CT if we need to know. And yet, if you have muscle wasting, your mortality from advanced liver disease for etiology is much, much worse. So many of these things feed on each other, and they sort of cause each other as you get worse in your fibrosis stages, if that makes sense.
That was very helpful. Thank you.
There's another question about FIB4 and FiberSure.
Okay. FiberSure is not FiberSure. So this is important, and let me get out of this. So FiberSure, actually, they have a test for fatty liver that never caught on. And the ELF test, whoops, I'm heading the wrong direction. My different windows for seeing and talking to people hide some of my slides. I should go to slide short review maybe. So the, oh, where's my ELF test? Well, let me just describe it. So the FiberSure is a proprietary to Hep C test. They're measuring markers that don't correlate with fatty liver. And I've actually had providers accidentally order it in fatty liver patients and get goofy numbers. I think what everybody in corrections is going to have to get accepting of is we're going to have to decide how to triage our patients. Now, the enhanced liver fibrosis test is a proprietary blood test. It's just under $200. And so that's one option versus getting in a relationship with, in fact, I'm actually in negotiations with our local hospital who doesn't have elastography services to get the EchoSense FibroScan machines for my community patients, because I just can't I can't stand the state spending $2,000 on a Medicaid patient when it should be a $200 test. So I'm trying to talk our local hospital into getting a FibroScan machine. In fact, the machines are the size of a laptop and incredibly portable. But the FiberSure is a Hep C specific test, and you can't use these tests out of the diagnosis that they're approved for. Does that make sense?
So somebody's asking about insulin contributing to NAFLD or cirrhosis. Does long-term insulin use contribute to it, or it seems like it would maybe make it better if you were controlling the diabetes better? What do you know about that?
So unfortunately, sulfonylureas and insulin, I didn't include that, but the ASLD lists medications that are neutral on. The sulfonylureas, I think, are pretty much a done drug class, with the exception of a couple. In fact, I'll bring this up in NCCHC talk, but sulfonylureas are not friendly with weight gain nor cardiovascular. So they're really out with any hints of NAFLD. Insulin is actually neutral. You tend to get tremendous weight gain though, but controlling diabetes is important. But as I listed, the AACE, the ASLD, we're going to see metformin, I believe, as a third line drug, and the ACE and the AACE have already new algorithms included and up to date, where you're to triage your diabetic patient by whether they have cardiovascular, kidney, or weight as their highest priority, and then choose an SGLT or a GLP first, and then the other, and then metformin really, I think it's going to become a third line drug with what I've seen from the new diabetic guidelines. And the ASLD, most hepatologists now have included an endocrinologist on their staff. So what you're going to see, I think, more and more is the American Endocrinology Society and the ASLD joining forces on many of these guidelines. And I think you saw it last year with the guidelines from the AACE quite radically changing the 2018 AASLD guidelines. And then these new guidelines from the AASLD being just minor adjustments. So does that answer that question?